morning, everybody. We want to thank our program sponsor, who happens to be Novartis. Let's give him a round of applause, all right? Our community sponsor is TG Therapeutics. They should be given a round of applause as well. I want to thank our exhibitors that we're here today. Again, we need people to be here, to be at the programs, to show you all what's available for those that are living with multiple sclerosis. So I want to also thank Biogen, EMD Serono, Genentech, Mallinckrodt, Modus Nova, and we had also Dr. LaGanke's research team. So let's say thank you to all of them too. We're going to get started with questions that I'm going to go back and forth with the two different doctors. And the first one is, let's just play ping pong here, right? I don't have to say your names. Let's start with Dr. LaGanke, and then Dr. Boster will be next and back and so on. All right, first, can you explain why MS is different in every person?
Because every person's different.
Hold it up.
I am.
Hold up.
Every person's different. So, your life experiences, your other diseases or health, and where the lesions are cumulatively in your brain and spinal cord optic nerve are different than somebody, your neighbor, let's say. But you share a lot of similarities. So fatigue is very common. Most of you probably experience fatigue. But the MS can occur at any portion of the brain, any part of the spinal cord. So your symptoms are going to be a manifestation of that. I know in neurology residency, there was a question: what neurological symptom cannot be due to MS? And that was a tough one. But anything that's observed by the brain or spinal cord can be affected, and not everyone has the exact same pattern.
Thank you. What are different types of multiple sclerosis?
One of the types that we don't talk enough about is called RIS, radiologically isolated syndrome. When someone has MRI that shows MS, but they haven't had a symptom yet. And we diagnose that increasingly because lots of people get MRIs when they go, when they sneeze and they go to the emergency department. If you've had one attack and your MRI looks a particular way, we call that CIS, or clinically isolated syndrome. And if you've had more than one attack, we now call that relapsing MS. If you had relapsing MS for quite some time and you haven't had relapses recently, but you're starting to get a little bit worse, we call that secondary progressive MS. And if you haven't had an attack, you've just been getting worse since the get-go, we call that primary progressive MS. I'm going to tell you guys a secret. It's the same disease. They're just different manifestations at different times in people's lives.
Thank you. What is secondary progressive MS with no relapse?
So secondary progressive MS without relapse is when you are worsening and have not had an attack with MS. It usually occurs, 12, 18 years on average after a course of relapsing remitting in patients who haven't been treated. And as I mentioned in my talk, it was significantly impacted by just the introduction of our injectable medications. The interferons and Copaxone had a significant impact on lessening secondary progressive disease. So doing something early was helpful. But as Aaron alluded to, and I did as well, the stronger you treat this condition earlier, the less likely you are going to venture down the secondary progressive pathway.
Amen.
Thank you. So if a new person comes into your office and they're newly diagnosed and they show up with a caregiver, firstly, do you want them to show up with a care partner? And secondly, how do you go about explaining multiple sclerosis to this new patient?
How much time do you have? No, I'm joking. So do I want you to show up with a care partner? I demand it. You don't get to have MS by yourself. I need to meet your wife. I need to meet your daughter. I need to meet your brother. I need to meet your uncle. You do this with a team. And so I want you to bring the team with you. I don't view the unit of measurement as you. I view the unit of measurement as the family. And so it's the village that's going to help make sure that we live our best life, not just you by yourself. So it's very, very important to me. We don't learn about MS in one day. And if there's anything I've learned doing this for a few years now, I used to not have gray here. It's that we're going to figure this out slowly together over time. And I think the key here is that we allow opportunities to see each other with frequency, where I can look you in the eyes and you can look me in the eyes, and we can start to up your game and slowly start to understand this disease. At the risk of self-aggrandizing, I made a YouTube channel so I can refer you to my YouTube videos and you can up your game at 3 a.m. in your bathrobe by yourself when maybe that's a better time for you to learn.
Thank you. Very explicit. What
Woo.
do you find typically works in your practice when communicating with the patients and the family members?
Oh, that's a long, long question. So, one is to try to put it in terms that people understand. Try to put this condition in a way that makes sense to you. I could use big words that just go over your head and really don't make me look good, but don't help you at all. So it's trying to get down to the nitty gritty. And then we're looking for NIDA. So our goals, we should have shared goals. We're looking for no relapses. We're looking for no new MRI lesions. We're looking for no change on your neurological exam, which means we have to examine you. And unfortunately, a number of people don't examine you when you come to clinic in our profession, which is sad. But we need to do that. We need to communicate what we find on those and what our objectives are so that you know what you're going after. You know what your goals are. And you're going to do what you value. So if you have a value of achieving that, then you're going to work for that. And we're going to work for that. We're going to work hard for that. The other thing is to understand the psyche. So I, like Aaron, lived in a family with MS. I lived with it every day since I was 2. And so you see how that affects not only the person most tragically, but also the family unit dynamics, not going here, not being able to do this. It's not the person with MS's fault that that's happening. Could have been me, could have been somebody else in the family. It's not their fault. We don't need to lay fault on the person. We need to encourage them. But it was a part of the family. So he and I both went into this not to just take care of the single unit showing up in the clinic, but it's the family as well, to make sure they understand and they can best care for the person and understand what's going to happen to their life as well. And it doesn't have to be bad.
Thank you. We hear from so many patients when they speak with their neurologist about going on to a specific treatment that their doctor disagrees and tells them what he or she wants them to take. This is especially true with community doctors in more rural areas, probably because they just simply haven't learned enough. But what can the patient do if this happens? What can the patient say? Where do you want to steer them?
You have one life to live. It's your body. It's your brain. Hell, it's your insurance money. And so the doctor is a partner, all right? But you're in charge. And so what I would do is I would say, Doc, that's fantastic. I really appreciate you educating me on that. That stated, I feel more comfortable going this direction. Are you going to support me in doing that? And then you have a conversation. A tip or a trick is to bring a team member, all right? Bring a team member, and that way they can support you. And they can say, he's been reading about this for a long time, doctor. Will you consider what he's saying? And you can gang up on him a little bit. Remember, you're in charge of you.
So, of course, we have another question that will usually require a very long answer, but we have to keep it short. So here we go. Can you please define or explain in the most ideal circumstances as to what a comprehensive MS team would look like when addressing symptoms of MS?
Yeah, it depends on what symptoms you have. So some people have one attack, they had optic neuritis, they have nothing else. They need me to follow them, and they may need a neuro-ophthalmologist or an ophthalmologist, depending on how affected they are. But there are people who have stiffness in a wheelchair, bladder difficulties, fatigue, you name it, pain, chronic pain. And so people who deal with those various aspects are our assistants. You know, we're working as a team to try to globally help you. And some of those things we're very adept at treating when you don't need to go see a specialist, and probably do better than the specialist in some cases, especially if they're not used to taking care of a lot of MS. But in other instances, they can be very, very helpful in ways that we can't be helpful. And so we elicit a team that, you know, maybe with mental health and with urology and with GYN issues and with men's health and nutritionists. So it can be a very, very comprehensive, or it can be much less so, all depending on how many symptoms a person has.
I can piggyback off that very quickly. Poor Stuart. You don't have to have every single human being in one geographic location to have a team, right? So some centers, they have everybody right there, which is really great. Some centers, they know who to call, and they've got someone who is an expert at mental health that will see those patients. So the point here is you need a team, but I do want to just point out it doesn't all have to be in the same geographic area.
Yeah, that's a good point. And that we learn who the best team members are. So we know who the urologist is who takes care of most of MS urology issues in the area. So, we hopefully can facilitate that to not someone who's necessarily local, but the best person for your particular problem.
Thank you. So our organization is known for providing many programs in very deep rural United States. All right. And to find MS neurologists are like impossible unless a person drives 2 or 3 hours, or if they're lucky. But worse is that they can't get symptom management doctors in those areas. So my question is, what do you recommend to people who live in these rural regions to find urologists or pain management, PTs, psychologists, OTs, social workers, etc.?
So a couple things. Number one, that's a conversation to game out with your MS neurologist. When you see your MS clinician, you say, hey, I don't live near you. If I have a problem, how are we going to tap on someone to help me? And first of all, let's hear what they have to say, because they may come up with some resources that you weren't aware of. Number two, I need you to have a primary care doctor. When I was a little munchkin before I went to med school, I thought I was going to do every single thing for an MS patient. I was going to do all the heart, the lungs, I didn't know what that meant. And I can't do all the things. And I desperately need you to have a primary care doctor local to you. And so I see patients from all around the United States, and I'll call the primary care in Missouri and say, hey man, I need your help. I need to get this person in to see an excellent pain doctor, and I don't know anyone in your area. Who do you recommend? And so between those two team members, the neurologist who's maybe seeing you a few times a year for your MS, and the local primary care, we can normally sort it.
Thank you. Next, I believe that you spoke about cognitive issues. All right. So, but many people just know it as brain fog because they can't remember the word cognitive. So what are your recommendations for people who have brain fog?
Well, first, most common cognitive problems in someone with MS is speed of processing complex information, and then attention and concentration, and and certain parts of memory. So if a person is faced with a task, I can't learn things as well, they're trying to understand and their attention span goes, that's not a very good combination. So you have a lot of cognitive issues where you just can't get it as quickly or get it at all like you used to. There are word finding problems, and that's due to frontal lobe lesions where you formulate the word in the front of the brain, going over to the middle part, and you can't get it there. Hits a scar, can't get through. So you know what you want to say, and you have to come up with another word. Or thought blocking, where you're in a conversation, then it vanished. You hit that scar, and the thought's gone. Don't know what you're talking about. Those are very common issues, and some of them have different treatments to them. Memory is different animal than the other cognitive issues. But one of the things that drives cognitive problems the most is fatigue. So memory and cognitive function requires energy. So if you know you have a dinner tonight at Uncle Joe's house, it's in your brain right now, and that little gerbil's kind of keeping that memory going while you're listening to us. That consumes energy. You already have an MS energy deficit. You're already fatigued. So we really see a lot of improvements in cognitive functioning when we improve your fatigue. So we really try to help fatigue and other little memory tricks and other cognitive issues that way, engage people in activities. You have two sides of the brain, a verbal side and a math side. So you need to be working on both sides. If you don't use it, you're going to get worse with it. So.
Thank you. Next, when are medications for MS not effective?
When are medications for MS not effective? So I want to keep you on a disease-modifying therapy unless one of 5 things happen. If you have an attack on the therapy, then it didn't do what I wanted it to. That's like saying if you got pregnant while taking birth control, it didn't work, mom. The second thing is if you have a new spot on your brain despite taking an MS medicine the way you're supposed to me, that's the same thing as an attack. And I'm not okay with that. We're going to have a conversation with your medicine and either kick it to the curb and take it out of your phone and tell them that you're going through some stuff and you'll call them and you don't call them, or we're going to put them on punishment, all right, and give them a warning and say no more. If your exam is worsening despite taking the medicine, that's a point of inflection when I want to kind of look at things. If you no longer tolerate your medicine, then it's not a good medicine for you. And if the medicine is no longer safe, then it's not a good medicine for you. So if one of those 5 things happen, I'm going to raise the question, is this a good option? Do we need to do something else? Otherwise, we're going to keep on keeping on.
Yeah, so that's the home run of therapy that I was talking about since 99. And melding 2 of those points to make it 4 is safety and tolerability. So those 2 together. And then the same things we talked about. That's what we should be seeking. We should be seeking perfection as far as we can get it in the brain and relapses, and then also keep the medication safe and well tolerated. So that's our goal. And if you're not achieving it, we're looking to do something else.
How do you know when a patient is relapsing, and what should that person do, and what should the person with MS recognize?
So I went over this a good bit with true relapse and otherwise. We have a new neurological deficit lasting at least 24 hours. That's our research-defined criteria for having a relapse. So if you have something you've never experienced before lasting at least 24 hours neurologically, that's on the docket to say we're having a relapse. Now, as Aaron said, there are some other things that can cause neurological worsening. We have to be aware of that. But that's the first trigger that I need to go to the neurologist's office, or I need to get that treated. I need to look at this as possibly being a relapse, because the longer we wait, more damage is done. The scar is bigger, more likely you're not going to be the same person at the end of the treatment for the relapse. Pseudo-relapse is very common. Stress-associated worsening happens a lot, so we don't need to give steroids for that. But anything that changes, and especially when you're young in a diagnosis, and I'm not sure if this is a relapse or not, you need to let us know. We can decide that. We've been doing this a long, long time. And if you're a little confused, not sure, I don't want to bother the doctor. Let us know what's going on, because we want your best neurological outcomes.
So you say when things are slightly different than what's normal. Is there anything more specific that you could point to that a person might see?
If you have a new neurological weird thing going on, and it's going on for longer than a 24-hour period, call us. We'll help you sort it out. I don't want you to play Dr. Google. All right, I'll pit my medical education against Dr. Google. You are a you expert, and I read things that you didn't have to read so that you don't have to. Together, we're a team. You bring me that information, boy, we're going to sit down and sort it out together.
Thank you. There are many that actually feel that they're having relapse, but they try to call their doctor's office and can't get through. Nobody calls them back, or it just goes to voicemail, or they could leave a message somewhere, send a text, whatever, and can't get through to that person. What do you recommend that they do if they cannot be seen by their neurologist?
Is hopefully we have a team. So it's other members of the team. If for some reason you can't get a hold of the neurologist, you have a primary care physician, get a hold of a primary care physician, or someone else on that team who then might be able to get a hold of us in another way, or something along those lines. But at least you need to seek care, and they can direct you. They're usually pretty good at managing big things. So going to the emergency room, going to somewhere to seek care through your team member, I think is advisable. The other thing is, if you're close to the neurology office, show up on a doorstep. Come on in. I have new paralysis, couldn't get through. Show up at the doorstep. You may or may not be directly seen, but you're going to get taken care of. Your problem is going to be managed. There's going to be a plan that's formulated. Okay.
This is a question that you need to pose to your neurologist when you see her next. Say, hey, FYI, as we do this together, if I have a problem and it's like the weekend, what am I supposed to do? They'll tell you their plan. You know, I live in Columbus, Ohio, which isn't near here, and I had to fly down here. And so I left clinic halfway through Friday, and I have amazing nurse practitioners that were holding down the fort. If something bad happened, we have a plan. And so you need to know what that plan is.
What up all this because we hear from many people who wind up at emergency rooms, and they do it because they just can't get in touch, or they don't have centers like the two of you have. They have a small community doctor somewhere, and it's only the doctor. There's no nurse practitioner, and they wind up at their local ER who are more clueless than some of the doctors even that are in those areas. And so my question, which was asked of us to ask you, should they go to an ER, or should they try to push themselves until they eventually can hear from their neurologist?
The ER is a final default, but you got to get taken care of. So it's not pushing through. If it's a new neurological problem, and we really think this is a relapse, or you think it's some other urgency, you need to get seen about it, not wait the weekend to have that taken care of. So I would not push through, not put off, being paralyzed on the right side for 48 hours. A lot of ERs will have various competencies, but a lot of them these days will default to give you some steroids. And that at least will pacify things until you can get some other care. So that's going to be better than not doing anything and watching your leg get worse and worse and worse, and we may not be able to recover it. So ideally, we don't go to the emergency room. Ideally, we have a plan in place. Ideally, you have some place to go to get some care before then. But I would not sit the weekend and not go get some care.
What he said.
Thank you. So next, combining two, what's the average recovery time for an MS relapse, and what are the treatments available for MS relapse?
So Dr. LaGanke did a bang-up job of going over treatments for MS relapse. That's steroids, ACTH. There's other things like IVIG, total plasma exchange. I don't know that there's a usual recovery time. We like it when people get better during the treatment, and boy, that makes us feel good. People can continue to relapse for months. And so I can't give you it's typically 17.4 days because I think everybody's different, and each relapse can be different. You can have a relapse that recovers very quickly with steroids. You can have another one that doesn't.
And by the way, it's not that I forgot that he spoke. Well, it's not that I forgot. Yeah, I guess I could say I forgot that you spoke about it. So we're at that point.
We got you, Stuart.
Yeah, we got it. Exactly. All right. If a person is on a high efficacy treatment, why should they even relapse?
No drug's perfect. People also relapse because they don't take the medication as they're supposed to. So that's one thing. We have to ensure compliance. But not any medication is perfect. We have very, very good medications with very high effectiveness at keeping relapses down, but none of them are perfect. Some people develop neutralizing antibodies against the particular therapy. It renders it ineffective, and therefore they're going to relapse. But even in the best of medications, none is perfect.
Thank you. Next, we're a little bit more than halfway now, everybody. Going good. How often should a person have an MRI, and at what strength?
So sometimes the patient will come to me and say, Dr. B, can we skip the MRI this year? I feel great. To which I say, that's exactly why I need an MRI. I don't need an MRI when you're having disease activity and I can see it clinically. I need an MRI to, quote, look under the hood, end quote. You're not a car. I'm using an analogy. To see if there's subclinical disease activity. I like to get an MRI of the brain about once a year. And I personally like to get an MRI of the cervical spine about every other year. And the reason I'm doing that is to make sure that we're not surprised. You're taking a medicine, you're dealing with the cost of the medicine, you're tolerating it, you're dealing with the side effects of the medicine. We want to make darn sure that it's working. Because if we see new spots on your brain or spinal cord, it ain't working. And the way that we sort that out is by scanning periodically.
Thank you. How is AI helping to diagnose through MRI?
Dun, dun, dun.
Through programming and making platforms that say if a lesion occurs with this size in this location, if there's a central vein sign, if there are pearls, if there's atrophy without other. So it's programmed by an individual for things that we typically see in MS. And you have an output from AI that will tell you whether a person's MRI has worsened. It's a little hard with a ton of lesions to see a subtle change necessarily, and that'd be more of a programming of the brain and outlining lesions and coming up with volumes. We're not there yet, but We have to be a little bit wary of AI because AI is the product of somebody. And in MS, we really have two extremes. We have the nihilistic treaters who will put you on minimal medication because they don't want to give you a side effect and hope that you don't progress. And then you have very aggressive treaters. And some will treat with a new MRI change. Some will view the no man's land of the brain as being possibly an area that's involved with MS. And others say, if you ever have lesions in the deep subcortical part of your brain, well, you probably had a migraine or you have small vessel disease and it can't be MS, so you don't have MS. Yet most of the new active lesions in MS occur in that particular location. Most lesions on autopsy specimens are in that location, but they're dismissed because they can be due to so many other things. That's not specific for MS, so we don't count it. So if you have someone who's programming the MRI who has that viewpoint, then MS is going to be diagnosed less. And if you have someone who calls every little spot in the brain as MS, you're going to have a program that diagnoses more people, too many people with MS. So AI is a product of how it's programmed, and that's people. And there's not a consensus in a lot of things with MS in the MS centers. They're really two opposite poles of treatment. So be wary of that. But it's moving forward, trying to allow people who don't do MS a lot, community doctors, to be able to diagnose MS with certain findings on an MRI scan. I don't know what else you have to say about that.
It ain't magic.
Thank you. Next, how effective is the MSDA octave testing? And please explain what the MSDA test is all about.
Show of hands if you've ever heard of the term biomarker. You ever heard of a biomarker? A biomarker is a medical test that tells you something about the human being. The number one biomarker that we use in MS is the MRI, where we're looking at structure. We now have what I think is kind of an exciting blood test, which is available, which teaches us about some aspects of your MS. This has been validated. It's approved by the FDA. It's not covered by most insurance, much to my chagrin, which means when we use it in clinic, patients sometimes have to pay a couple $100 for it. But when you do this octave DA test, it looks at a bunch of blood, and if they come back really elevated, your MS is not under good control. And if it comes back really low, that's very reassuring that things are probably in the right direction. Now, this blood test doesn't replace me talking to you or examining you or getting an MRI, but it's another emerging biomarker that I find to be very useful in practice. It's called the octave DA test.
So, we find it very helpful as an adjunct and find it more helpful over time. Is the score going up, score stable, score going down? And there are certain components of the octave test that are particularly interesting. One, neurofilaments. So the serum neurofilaments is being looked at as a biomarker just by itself, but that's one of 18 components of this test. So I look at that one, which is really more predictive of relapses and worsening relapsing disease. And then there's something called GFAP, which is more looking at progression of disease, maybe independent of relapse activity. So I look at the whole score. I look at the change over time, and I just kind of give a little bit of an eye wink at those two subcomponents as well.
Thank you. Going forward with this, how often should the test be performed, and is it FDA approved?
Yes, it's FDA. It's approved. It's validated for new lesion on the MRI scan in a 120-day window, 60 days past, 60 days forward. That's what it's validated for, to predict new lesions or demonstrate recent lesions. There's no magic. There's nothing hard and fast. So what I try to do, and again, it's a little more than a few $100. It's $2,700 for some people who brought the bill in. For some, there are other issues, and I can talk to you about the cost of that and how to maybe get past that, but that's a separate discussion. I like to do it ideally yearly. So MRI, 6 months later, octave test. 6 months later, MRI, which is a yearly MRI. 6 months later, octave test, which is a yearly. So at least every 6 months, we're having a biomarker evaluation of what's going on with you.
If money grew on trees, which at least in Ohio it doesn't, I would probably get this test once every 3 months.
Thank you. Next, What is the difference of mesenchymal stem cells and HST human stem cells and embryonic stem cell?
So stem cell transplant is not a medicine, it's a procedure. And it's been used for a very long time to treat really scary cancers that don't respond to chemotherapy. And stem cell transplantation has been started to be used in research in the United States to treat certain types of MS, as well as in other countries. Stem cell transplantation is not a cure for multiple sclerosis. Now, this question is kind of a highfalutin question, asking about different kinds of stem cell transplantation. Instead of answering the question, let me just very briefly share with you what a stem cell transplant is. We extract stem cells out of your body and we put them on ice, right? And then we murder you. We give you lethal doses of chemotherapy, which would destroy your immune system for the rest of your life. And if we stopped right there, you'd get an infection and pass away. But before that happens, we give you back the stem cells. The stem cells do not treat the MS. Destroying the immune system treats the MS. The stem cells keep you from dying. And when you hear about hematopoietic stem cell transplant, embryonic stem cell transplant, mesenchymal stem cell, those are just different sources of the cells. Is stem cell transplantation exciting? Yeah. Is it prime time? No.
Thank you. Next question is, for all the people that hear or see the commercials on television about rejuvenating your stem cells, what can you tell them about this?
I'm sorry.
What Aaron said. No, I mean, there are these companies that capitalize on things, and the fly-by-night where we make stem cells. Come see us, give us $20,000, $40,000, and we'll give you stem cells. And they're not really validated. So, I mean, desperate situations often lead to desperate solutions or attempts at treating that, and then some people capitalize on that. I mean, we've been talking about stem cells since 1999. It was a hope in MS, and we're still not there. It's very frustrating that it's not globally known. Yes, it works. No, it doesn't. Works in these, doesn't work in these people. It's not there yet, and I wish it was, but yeah.
Great. Next grouping. How do you speak with your patients about disease progression?
We have to be honest with each other. People come and see me and say, "How you doing?" "Good, doc." And I oftentimes say, "Is that a socially polite Midwestern good, or are you actually doing good?" 9 times out of 10, they'll say, "Actually, I'm doing kind of crappy." I'll say, "Okay, let's start there with crappy." We have to be honest with each other. And so I need you to be honest with me when things aren't going very well. And I need to be honest with you with what I'm seeing. That's where things start, right? And if things aren't going well, we got to admit that's the case, and then we got to game out what we're going to do to try to make it better.
Right. Piggyback. We can't know what's going on with you unless you tell us. We're not clairvoyant. And I mean, clinics, I mean, most of we're a little bit tardy in clinic. We're a bit tardy in clinic because I'm not looking at the band-aided symptom of what's worse or what's happening. It's why is it happening? Spouse has cancer, stage 4, going through chemo, surgery, gonna die, 2 years later dies. Your MS is not going to do very well in those 2 years. It doesn't mean you're having progression of MS necessarily, but your function's worse. So there's something called SAW, or stress-associated worsening, which you can't get at if you don't take a history. And I don't take the time to understand what's going on with you. Trying to get disability, they foreclosed on my house, this is happening, I'm having recurrent pneumonia or bladder infections. Something is causing that worsening, and if it's not MS, yeah, it can be PIRA, but I think PIRA is way overcalled. I think there are other things that are happening to make your function worse. Even normal aging. Unfortunately, we all lose neurons. And if you needed those neurons to cover for the damage you had and you were doing okay, and now you lost some of your normal neurons and you're starting to progress, well, that's not MS progressing. That's you getting older, which is now impacting the function of your MS. But we don't need to switch your MS medication because you're not walking as well. If it's due to aging, if we feel comfortable with that. So we really have to delve into what it is that's making you worse. And it takes time. takes time to talk and understand what's going on in your life. Don't just tell me your symptom, what's going on. Because if we can get at that, a lot of times we can have powerful positive impacts, and it doesn't necessarily mean switching medicines.
Thank you. So that leads to my next question. How do you tell the difference between, how do you explain the difference between a person aging or that their MS is progressing?
It's tricky, but if we're going to find the answer, it's through discussion. It's not through an MRI. It's not through some tuning fork or a hammer that I beat you with. It's through talking about exactly what Dr. LaGanke just laid out.
Regarding high efficacy MS treatments, are there any risks for those treatments?
Never. So kind of the general categorization is lower efficacy medications are generally very safe. Moderately effective medications are moderately safe. Highly effective medications have some rare serious side effects usually associated with them, and by the mechanism of how they work and affect your immune system. But it doesn't mean that that's a huge risk for everybody. It's usually a very small risk of a very serious thing. Undertreating MS is a very serious thing. MS getting worse usually doesn't get into that equation. It's like your chances of getting worse on a low efficacy medication is really high, and you don't want to live with MS getting worse and worse. When we had something that could have helped you, it may have required you to take a small risk of a serious side effect, but your chances of having a high quality of life is much greater. So, and it's weighing those out. You're the ultimate customer. You have to be comfortable with that decision. Hopefully, we've discussed it well enough so that you can make a valid decision.
To piggyback off that, I'm much more scared of undertreated MS than I am of the side effects of the medicine. And please follow me here. We have to place the risk benefit of the medicine inside the context of the risk of the disease. That's very hard to do, but that's what we want to help you do.
Thank you. There's a person who contacted me the other day. She's watching this program online. She lives in the Atlanta area. She's approaching 70 years old and has been on Tysabri since 20 plus years ago. And all of a sudden, her metropolitan doctor wants her off of Tysabri and doesn't want to put her onto anything else. Yet we've always heard that you can't just come off of Tysabri without being put onto something else. So what can be said to this person?
Well, giving the benefit of the doubt to the doctor, that physician should have some sound reason and be able to explain that to you that's satisfactory, which unfortunately probably would not be the case. But some doctors have more comfort with certain treatments than others, and they don't want to have any significant adverse side effect. But again, they forget the side effect of undertreatment, which is much higher percentage than a side effect of the treatment. If someone's tolerated Tysabri for that long, let's assume they're JC virus negative, there would really be no reason to come off that treatment if the patient was still wanting to be on that treatment. There's no reason to come off of that treatment. There's no rule or no other particular reason why one would. So it's share that opinion, disagree. It's okay, we have different opinions, but if they're unyielding, then it's your body, your right, your choice to go where you go.
Thank you. Next, concerning another one on high efficacy treatments, should these only be used for a person who's showing progression?
No. So Dr. LaGanke, in his discussion today, laid out very important information. The earlier you start highly effective medicines, the better you do long term. Starting a highly effective medicine as early as possible is key to changing the trajectory of the disease. We don't want to wait down the line and then start those medicines because we're not going to get the same bang for our buck.
I could just add a small point to that we're talking statistic populations, right? These are statistics for the population. Some of you may be on Avonex or Copaxone or Betacern. You haven't had any worsening whatsoever for 20 years. We're not saying you need to stop and go on a high efficacy medicine. That's a highly effective medicine for you. So we just use statistics when we start out treatment. The chances of you doing exceptionally well on an injectable from the get-go is much lower than the likelihood that you're going to do well on a high efficacy medicine. But some of you may be on a less than high efficacy medicine, but you're doing great, fantastic. We would not come in and say you need to switch because all the data says the earlier on high efficacy, the better you do. As long as you're showing up in front of us, we're assessing you for relapse, looking at your MRI scan, etc.
Okay, next, a person says that they were showing a new symptom, and they went to their doctor about this, and their doctor automatically just said that he wants to switch them to a new medication, where they actually felt that the current medication, they're not actually progressing. They don't see, they just got a new relapse. I mean, sustained a new symptom. And what can be said about this?
So again, this goes to the relationship between the patient and the clinician. It's an intimate relationship. It's an intimate relationship. We're working as a team to game out how for you to live your best life despite having this condition. And so you don't have to agree on everything, but that should be a discussion. At the end of the day, like I said earlier, you're in charge of you. It's your body. And so I can come up with all kinds of great ideas. Doesn't mean you agree with me. You're still in charge. And so I just think that needs, I would like that patient to say, Doc, I'm not tracking what you're saying. Help me understand why you need to do this.
Great. Next, we have, do any of the new medications actually help you feel better, or do they just work on the disease itself?
The goal with these medications is not to make you feel better tomorrow. They're to keep the disease from advancing. Yet, some of these medications, by controlling your disease and allowing you time to heal up from some of the recently accumulated lesions, you actually feel better, you do better. If it allows you to not deal with another relapse, another issue, you might be able to rehab and neuroplasticity and recover function over time. So ultimately, you are going to feel better. But if the question is, am I going to take this and I'm going to feel wonderful, and you're talking about a disease-modifying therapy, that's generally not. Symptom management medicine, so disease-modifying therapy, the key part there is to control the MS. But there are tons of symptom management strategies, therapy-wise and medication-wise, that will make you feel better. We have a lot of things. And if one doesn't, then we're not going to go with that. We'll go with another one. Keep trying to improve the symptoms to help your quality of life better while we're still keeping the disease at bay.
Think of a disease-modifying therapy as a birth control pill against future disease activity. So if you have 3 kids and you start birth control, guess what? You still have 3 kids. They don't go away just because you started birth control. You're on birth control because you don't want a 4th unplanned kid, right? And if you're confused, go hang out with your 3 kids. So if you've developed disabilities because of MS disease activity, starting a DMT won't make that necessarily go away. That's the reason why we're on the DMT, so something else doesn't happen.
Thank you. Why are so many patients told by their neurologist that at 65 they need to stop?
Oh, back in the day before we had many medications, some people would burn out with their MS, quote unquote, and usually up in age, and they'd stop having relapses and stabilize for a while. And I think that's kind of kept on in some people's mind, that you can burn out your MS at a certain particular age and you don't need to spend the large dollar on the medication and it's not doing much for you anymore. That's really not terribly accurate. And there's biological age and chronological age. So not every 65-year-old is 65. And there are measures that actually we can do with biological aging that says what your biological age is. Some are older than 65. But there's nothing magic about a particular year and when one should come off treatment. It's kind of Russian roulette, but again, you're in charge. So you've been stable 20 years, you come in and say this, I might say I don't think that's a great idea for this reason, that reason, or whatever, but you say, I'd like to do that. Again, it's your ultimate decision. I'll provide information that might say different, but then I'm not going to say, okay, well, you're not doing what I say, you're not coming back to the clinic. I'm going to follow you. I'm going to take care of you. If you decide to do something that's different, you may have had some kind of intuition or whatever, and that worked out perfectly for you. Wonderful. But I'm going to be there. I'm not leaving you if you don't agree with me.
Thank you. One last question, and we're like right on time, so I feel great. Where are we in research for multiple sclerosis, and is AI to be a major factor for finding better medication options and repair of the myelin?
It's a very exciting time to be involved in MS research because there is a wave of innovation, and that translates into bringing new cutting-edge options through clinical trials to our patients and our practices. There's a lot of things that we're studying right now. Our current medicines have revolutionized the disease, but it's not a cure, and we're still working. And I shared with you during my quick chat today about that BTK inhibitor tolobrutinib and how excited we are. And there's a bunch of medicines coming down the pipeline. I'll reiterate something that Dr. LaGanke said earlier. AI is not a cure. AI is not magic. AI is like a really, really fancy calculator, which is programmed by somebody. And I don't think that we're going to find a magic answer because you type it into ChatGPT.
Thank you. Let's give a round of applause to these doctors. So before they leave, they're not leaving because I'm going to go around the room. I'm going to take your questions.
Hi, I have several questions, but I'll start with one. I recently heard that there was a study out about gabapentin and its use as a pain medication. This was in particular in cancer patients. And the results of the study was that long-term use of gabapentin caused dementia. What do you guys know about that?
Yeah, I haven't seen the study. It would have to be a really convincing study because medication has been used a long time, and now we're getting to the point where it's been used for multiple years where we may have some of these results, but I don't think it was prospectively followed. And people with cancer certainly have a lot of other issues that may affect their memory. They may have had radiation, chemotherapy, a bunch of things. It was similar to a study with benzodiazepines, the Xanaxes, Valiums, and so on, that the New England Journal conducted, and they said that a lot of people with Alzheimer's take those medications. They must cause dementia. Well, maybe they allowed people not to have heart attacks and strokes because they weren't so anxious and they got to live old enough to get to Alzheimer's. That might be a different answer. There's no proof that those medications actually cause that. Association does not mean causation. Because a person has been, it doesn't mean that it caused it. There may be some other reasons for that. We certainly would want to know that. We don't want to cause dementia in individuals with certain medications. But I think one study is a little bit light on that, and I don't know what the measures are and how they went about that to test them and other kind of medications that they may have been taking that may have done the same thing. So, and how old they were, et cetera. So it's hard to answer. I think it's important. We need to follow medications on the long haul because in studies are only usually a year to 3 or 4 years. So if there's some long-term consequence to them, we wouldn't know it from the clinical trials. So we have to keep our eyes open.
Hi, we appreciate Dr. Boster coming. My husband sends me a lot of your videos. My question is, can you get Dr. LaGanke to come up with a YouTube channel? We don't get to spend a lot of time in his office.
We're going to need to invite him not during winter time.
I grew up in Connecticut. That's fine.
When do you cross the bridge from relapsing to secondary?
Yeah, there's no real excellent measure. In the past, it was if you had worsening of your neurological function for 6 months without a relapse, that was the definition to say that you had secondary progressive MS. But there's so many other variables. It's really difficult to say exactly when you cross the threshold. I probably have a dozen people out of the 3,000 people that we follow with MS that I think have PIRA or PIRA going into secondary progressive disease. Just threw the kitchen sink at them and nothing worked. Nothing. They just went into this progressive phase after a period of relapsing, and there was nothing I could do to stop that, or that we could do to stop that. That's a very small percentage that way. But it's kind of a gestalt, I guess, a feel that this person's worsening. We don't have any other reason for it. It's happened a while. and that would kind of lead us to make that diagnosis. We're also shy of making that diagnosis because insurance won't cover medications if you have secondary progressive MS. And that doesn't mean that they're not effective. They haven't been studied. Doesn't mean they're not effective at slowing the rate. They may not be perfect at stopping progression, but they may be helping you in other ways. And we don't want to give the power to insurance companies. They didn't go to school. They don't know. They have different motives for making decisions. We're trying to champion your health.
Next question.
There's a drug called Foralumab, Foralumab. It's apparently FDA approved for Alzheimer's, and it may be in some sort of clinical trial or something for MS. It treats inflammation in the brain. Do you have an opinion or know anything about that?
Well, a church member came up and asked me about it a few weeks ago, so I had no knowledge of what that was. And it's actually not approved for either, but it is being studied for both. So it's something it's a monoclonal antibody being studied in Alzheimer's, and it's suggested it may have some effects in MS. So it's something that's pretty early, and it's in the development that way, but I don't know how it came out that people think it's approved for both, but yeah.
I just have a question real quick. You guys were talking about brain lesions earlier. Is there a drug being worked on to maybe repair those?
So a hypothetical cure of sclerosis would probably involve 3 different kinds of medicines. And a lot of what we have right now, a neuroprotective agent to protect against new damage, and a remyelinating agent to put the plastic coating back on the wire. Those last 2 we don't have just yet. There's a lot of research on trying to do something that is remyelinating, but it's not prime time.
Hey, Doc. Okay, so my question is, what is the most helpful way for your patients to describe pain or symptoms that's going to help you understand what they're experiencing?
I showed you flowers today, by the way. There are various types of pain. So it's just, pain's a difficult thing to describe sometimes. Very hard to describe accurately what pain feels like. It's easy when it's a shooting electric type of pain, or like when your hand's been cold in the ice and it's recovering and it has that numb, tingly, burning kind of feeling. But there's this deep aching pain in the bone. So you do the best you can, and we try to help and figure it out and ask maybe sometimes some pointed questions if we don't understand. Does it feel like your leg's heavy as well as painful? Or it's just, there are many different types of pain. There's neuropathic pain, there's somatic pain, migraines, of course, and headaches are a different kind of pain. There's a slew. So you just do the best you can, and we're going to try to guide you to get us to understand what kind of pain that is. Is it related to nerve, or is it related to tissue kind of pain? I don't know if you have.
If you imagine how you would describe the discomfort to your best friend, that's what I want to hear about. What triggers it? What makes it better? What's the best word to describe what it feels like? How's it coming on? How severe is it? What seems to be associated with it? And this is something that you can literally write down in preparation to come in to see me, because that way you don't have to think of all those things on the spot.
It feels like a jagged saw cutting through your skin.
For example.
Don't want it, yeah. No, what makes it worse, what makes it better, those kind of things can be helpful. But it's kind of like, how do you describe a taste of a peach?
Tastes like a peach.
There you go.
So I've seen some studies that have come out related to the use of red light therapy and how it can decrease oxidative stress, photobiomodulation. Do y'all have any, what are your thoughts on red light therapy?
We're both allopathic doctors. And so if something wasn't taught to us in our allopathic med school, we're taught to call it complementary because we weren't taught about it. Doesn't mean it doesn't work, just means we weren't taught about it. So I have 3 rules for non-conventional or complementary therapy. Number 1 is it can't be too expensive. And only you know whether that red light device is too expensive or not for your family. Number 2, it can't be dangerous. Unfortunately, red light therapy is not dangerous. And number 3, it can't be instead of something that I know works. So if you tell me I can buy this red light therapy and I'm going to stop my disease-modifying therapy, I'm going to feel sad, blue, and depressed. If you tell me that you're going to do both together, then I'll take that ride with you and we can learn together whether it helps you.
Yeah, it's been used a bunch in pain, for neuropathy, all kinds of different forms of pain. And some people do really seem to do very well with it. Of course, you always have the placebo effect, which is about 25% of the time someone's going to respond, even if it's not working, because they believe in it and they're feeling better. And that's wonderful. But it's not necessarily due to the intervention. So we always have to contend with that. Otherwise, it would be much easier for us to accept these things and say that's very effective. But we have to know that some people are going to feel better with it, and they genuinely do, but it's not directly due to the red light. So for us to prescribe it saying this is going to help you would be not accurate necessarily. So that's the quandary we're in. If there aren't really large studies, well conducted, with a placebo blue light or some kind of variant red light that doesn't have properties, then it's hard for us to endorse something because we don't have top level evidence to say that I recommend that you do this to your body. But like Aaron said, if it's not harmful, it's not going to do away with something that we know is working for you, and it's not going to break the bank, then we're generally fine with it.
So I have a question about fatigue. Dr. LaGanke, you mentioned, you kind of need to pace yourself, but also they'll tell you, you need to get exercise, you need to push yourself a little bit, otherwise your energy reserves start to go down. And I find myself struggling to balance. Like I'll overdo it and then put myself under, or I'll get lazy and start to sag toward the couch potato end of it. Like, are there any guardrails that you could point to for kind of trying to keep that in the right zone?
I'll let him start.
Absolutely. A dear friend of mine who is a neurophysical therapist taught me a long time ago a couple guardrails that I like to share with patients. One of them is, if you do a hard workout and you're kaput for an hour or two, that's okay. If you still can't walk up the steps several hours after the workout, you overdid it. Another rule that I like to use is the next day. If you get your exercise on and the next day is a normal day, you didn't overdo it. If the next day you're paying the devil's price and you're in bed, you overdid it. And the guiding principle in my mind is we don't want to use the high school mentality of, if I can run 1 mile today, I'll run 2 tomorrow. Remember that? So instead, what you want to say is, if you can walk 10 steps, giddy up. When you're ready, let's walk 11. I didn't say 20, I said 11. And let's do 11 steps until you can always do 11 steps. And then we're going to do 12, not 20. Slow and slow and slow wins the race.
Yeah, to be able to do more, ultimately, you have to do something. And so for walking, for example, say walk 5 minutes, 2.5 down, 2.5 back. If you're able to do that for a couple, if you're wanting to now try to get into shape, in 2 weeks, 6 minutes. And as long as you haven't had any untoward, in a week or two, it's 7 minutes. And we need to gradually build. It's not going to happen. I mean, I have that same stupid mentality. If I'm going to want to go get in shape, I'm going to go 30 minutes on the bike and I'm going to feel like crap the next day. As I still believe I should be able to do that, but you have to start really slowly and build yourself up. If I have this biceps and I haven't done much with it, it's out of shape, I can lift this weight. In 6 weeks, if I work it out gradually and better, I'm going to be able to lift that weight pretty well, and I'm going to use less energy. So people are afraid to do stuff because of fatigue, but if you get your muscle more fit, it requires less energy to perform an action, and you're actually going to have more energy. So we want you to get into shape, but it's going to take time. You have to have patience to gradually increase that over time and not overdo it.
Next question.
I have a 2-part question. How do you feel about the research that shows nicotine is beneficial for pain and inflammation in MS? And do you agree with 5-month treatment for Ocrevus instead of 6 to avoid the crap gap?
That's not a 2-part question. That's 2 completely separate questions, madam. So smoking speeds up MS by about 50%. Allow me to repeat, smoking speeds up MS by about 50%. So I don't want you to light a carbon-based thing on fire and suck in the smoke. I do not recommend my patients use nicotine patches for energy or for fatigue or for something else. It's one of the most addictive substances that adult humans expose themselves to. So I err on the side of no, thank you very much. Do you want to tackle the other one?
So, yeah, there are more influencers a day than we can keep up with anything. And so there's a lot of information out there about a lot of more natural substances or strategies. And I think some of the, nicotinic acid for Alzheimer's disease was recommended way back when because of the nicotinic receptors and memory and so on. And there's a lot of plausibility to a lot of the influencers' information. It makes sense. It's theoretically good. But until we really have good, well-controlled studies that prove that, it's hard for us to say, yeah, go jump in, because it hasn't really been studied to that degree. And so that's where I kind of stand on those things. I'm open to trying different things and having different modalities that aren't pharmaceutical agents. I'm open to that. But for me to recommend it without real good proof, that I think is substantial, I don't think that'd be disingenuous to say do that. With the Ocrevus in every 5 months, good luck getting insurance to approve it. That's the first problem, to get it every 5 months if you have the crap gap. More commonly, what we do is we amp up the anti-fatigue regimen in that month. So that if you're on a certain regimen for your fatigue, well, going into that starting the 6th month, we're going to go up so that your decline is going to keep you at a baseline if we can. And if that's not possible and 2 months out of your year, you're not feeling very well, we have to reevaluate whether that's the right treatment for you.
We will sometimes give someone a short exposure to a steroid a month leading into their infusion, which is done at risk. Giving steroids is risky, but in some cases that helps them coast into their infusion as well.
How often do you have patients that start out with the primary progressive? What's your go-to treatment for that? And do you think this new pill coming out will replace that treatment?
So I would submit that about 10 to 15% of people that present with MS present with primary progressive MS. And that's certainly what I see in my clinic. It's about 10% of patients. The only clinical data supporting its use in PPMS is with the medicine ocrelizumab, Ocrevus, from the Oratorio trial. And I typically start using a B-cell depleter like Ocrevus because of that data. It's very exciting to learn about new therapies, and I am very excited about the Perseus trial, which is studying tolobrutinib in PPMS, but the data's out. I don't know yet. And so I'm not going to weigh in until I can see that data, and then I'll be able to answer the question.
I actually got 2 questions. The first one is, I was just diagnosed a week ago Thursday. How can you tell if you've had MS a lot longer than what you was originally diagnosed, or when your first symptoms that got people to look? How do you know that, say, you hadn't had it for 10, 20, or maybe even your whole life?
One is to get a better history, make sure there wasn't anything that you might have blown off or thought was subtle or whatnot in the past that would be consistent with something that happens in MS. The other is looking at the scan. And if we see a scan that has 30, 40 lesions, they're not really active. They had to happen at some point in the past. Unfortunately, we can't well date them. Now, pure black holes are going to be a good, a bit further than just a lesion that doesn't have that component. But we're not really great at dating things as far as lesions. We just know that if you had a bunch, they're not active now. They happened some point in the past. And if you had a lot of them, the likelihood is that you had it for longer.
Yeah, my second question is, what is your advice for somebody that doesn't have a team or financial issues, or both?
So his question is, I'm just newly diagnosed and I don't have a team yet. What's your advice? So, sir, it will take you 2 years working with him before emotionally you realize that you got this. Now, I've been doing this for a long time, and so I say that with some degree of authority, that it takes families about 2 years to figure this. I don't mean intellectually. Intellectually, you'll understand what's being told you, but till in your heart, you'll say, okay, I can do this. And in that time, you're going to build a team. So I want to be a team member. He wants to be a team member. You're going to build a team. And so we're going to help you craft that team together so that we can make this disease as boring as possible. It ain't going to happen overnight.
But at this day and age, our expectation is high that we're gonna level this thing off. That it's hard when you first have changes. 2 weeks ago you're one way, and then the next week you're not. But we have really, really good treatments now. That if this one isn't it, we have another one. We have another one. We have another one. So our likelihood of stabilizing you and keeping you on your feet for the rest of your days from an MS standpoint, pretty high.
I want to add something to that as well. I was diagnosed in 1997. There were only 3 drugs available. You now have over 27 drugs on the market for this, and more coming shortly. And I would listen to what the doctors just said and just stand proud.
What can we do as the MS person to be more prepared when we come to a doctor's visit? What would you like to see?
So I prepare for your visit. Before you come to see me, I reread my chart and I look at your MRI scan so I can be prepared to see you. I want you to do homework too. I want you to write down your questions on a piece of paper. I want you to bring a list of all your medicines that are current, or I want you to bring them in a bag, right? I want you to bring to me any notes from other doctors you've seen since we met last. And oftentimes I want you to bring a team member to help you navigate. So we have very precious time together. I may only get to see you for half an hour or an hour once every 3 or 4 months. We want to make the most of that time.
I would prefer you not to bring a 27-page handwritten explanation of what's been going on. Although I appreciate that and the time that's spent to do that. I would like a bullet point. Have your questions, but bullet points of things that happen. That we can kind of go over, and that takes preparation. So that's homework. That's taking some time to think about the various things you want addressed or things that have happened to you since the last visit.
And I want to share that MS Fusion News has a tool, a 2-page tool on our website. You just click on it. It's called the Land of MS Communication Tool. It's a 2-sided sheet of paper that you print it, and everything you need for your doctor to know about your MS is somewhere on those 2 pages, not 27. All right. And you can fill that out, bring it in, give it to whoever it is that you're checking in with. They'll make sure to stick it in the folder so the doctor, before he walks in the room, sees what's going on with you and you're ready to play. Land of MS Communication Tool on the MS Fusion News website.
How do we with MS advocate for ourselves with primary caregivers when our MSologist is so far away and most primary caregivers look at us like we're crazy?
Well, hopefully there's a fostered relationship between the primary care physician and the neurologist so that you're being afar, we can address those situations that come up that they feel maybe ill-equipped to handle. And then hopefully there's a means of communication to the clinic that you can get to send an email, send a note, send a fax, send something to get our input and allow us to communicate with the primary care physician about things that need to be done that may worsen your MS, but are not MS related. They're primary care issues. Yet a lot of primary care physicians want to blame MS for most every symptom, so they refer you to us. But it would be helpful for all of our time if they would handle the things that are primary care that can make your MS worse. Some of that takes education and building a relationship too between us and them. Yeah. Anything else?
I'll add to that, continually upping your game. Look around the room real quick. See all these people here today? Everyone here deserves some attaboy because you took time out of your life to up your game and learn more about how to beat up on this disease. And I'm very, very appreciative for that because that makes you a more effective member of your own team. and it allows you to feel more confident in your discussions with your MS neurologist and with your primary care doctor.
Way to go. Ditto.
Do MS-induced seizures indicate a worse prognosis?
No. So seizures occur about 5% of people with MS. They don't portend a worse outcome. They start in an area that may short circuit and create a seizure. So no, there's not a worse outcome suggested or expected when you have seizures with your MS.
As a caregiver, what's the best advice you could give for anybody here that's a caregiver?
I dislike the term caregiver, and I prefer the term care partner. And the reason I prefer the term care partner is I think it's more reflective of the relationship, which is typically a two-way relationship, right? And so that's just words matter to me. One of the things that I think is very helpful when you're in a relationship with someone who has MS is to have open lines of communication. Let me tell you a quick story. There was a research study done where they interviewed 1,000 people with MS and 500 care partners, asking them all these questions. 2/3 of the care partners were scared to death their loved one was getting worse, but wouldn't say anything to them for fear they'd upset them. 2/3 of the people with MS were scared to death they were getting worse and didn't want to tell their care partner because they were scared of upsetting them. Which means 2/3 of people are laying in bed with another human that they love very much with the exact same concern and they ain't talking about it. So I want you to combat that. We need open lines of communication. Say, hey, I'm kind of scared about something. You've been stumbling a lot and that scares the bejesus out of me. Can we talk about this? That's the number one thing that I could ask you to consider doing.
Yeah, be real. MS isn't leprosy. It isn't anything else. It's the person the same person. So talk like you would in a regular relationship. Be open, discuss issues, treat them like a human being, and vice versa. If you have MS, don't feel like I'm not going to burden them anymore. I'm not going to trouble them with this or that. It's a two-way street. You have a condition. It could have been the other person. Your partners, you're in it together for better, for worse, in sickness and health, and have that discussion. It's not, you're still the same people, but battle different challenges, right?
Hi, thank you guys both for being here. The internet is filled with a lot of information, and I am just curious, what would you say to those naturalists that say MS is from parasites? Just take some ivermectin and you'll be good.
Well, first thing I'd say is common sense. Our most effective treatments for MS, just effective for the condition itself, chemotherapy, harsh chemotherapy, really effective for stopping MS from getting worse. And our agents that we have approved for MS, they suppress the immune system, some of them quite vigorously. Well, if you had a parasite in your brain and all of a sudden you took away the immune system, guess what would happen?
They'd die.
You'd get worse, right? You get a lot worse. But the opposite's happening. You go on really high-powered immunosuppressant medicine, your MS gets better. So number one, it just doesn't pass the smell test, right? And there are studies in the past where people took biopsied lesions and they saw evidence of measles and human herpes virus 6 and this and that, whatever, and say, well, that must be the cause of MS. And it's the same kind of thing where one doctor found parasites in every single MS lesion that he biopsied, so therefore it must be due to parasites. And it's just not accurate.
Thank you.
It doesn't mean, now, I will say that, ivermectin and hydroxychloroquine and those things, they may do other things that are helpful in the body outside of just treating a parasite. It's kind of like metformin, that's for diabetes, but boy, it may be an anti-aging agent. It may be a remyelinating agent. It worked in the animals with MS to help remyelinate lesions. So it doesn't mean that it's effective. It may be effective, but it may not be effective because there are parasites there. It may be effective by a different mechanism of action.
Yes. My wife's had MS diagnosed for about five months of treatment. So you'd say we're still in the 2-year. Depression is very much real. And with vacationing and different activities that now you realize, like as you said about living in Ohio, the cold, well, our heat is horrible. Do you have suggestions for things that we as I know you don't like caregiver, but as a care person, other things you can do to help with depression, other activities that, we were always very active, and now we realize that all of our activities are just debilitating.
Pick a number between 2 through 10. Pick a number between 2 through 10.
8.
8. Let's come up with 8 quick things we can do to help with depression right now. Number 1, you can get an extra hour of sleep every night. I'm being dead serious. Number 2, you can exercise as part of your lifestyle. Number 3, you can eat smart and avoid ultra-processed foods, fast foods, sugar-laden foods. Tea tastes delicious, but maybe not. All right. Number 4, there are medicines that doctors give you which can worsen depression. So you want to make sure that we're not on any medicines we don't need to be on. Number 5, you can engage in your community. Going to church serves a lot of purposes. All right. And that community is worth its weight in gold for many, many things, including being sad, blue, and depressed. Number 6, you can treat fatigue, because if you have fatigue, it'll make depression worse oftentimes. Number 7, there are excellent medicines that treat depression. I take antidepressants and they work really, really well. And number 8, you can see a talk therapist, someone who's not an intimate partner in your life, who acts as a sounding board to let you process things that are frustrating.
What if he said 9?
If we wanted to do 9, take a disease-modifying therapy for MS, because every single time you look at DMTs, we see that the patients on DMTs have better mental health scores than those that are not.
Yeah, depression is a primary chemical problem that requires treatment. It's worsened by stress and other things that are going on in life, but it's not caused by that. So typically, one will require an agent, at least for a period of time, to help reestablish that chemistry. But it's also 5 months into a diagnosis and what's going to happen in my life. It's talking that out and saying, what are your fears? And if someone has a paralyzing event and gets in a wheelchair, life's not over. You're going to figure out how to do it. So in your situation, which isn't that to that extent, you're going to figure out, we used to like to go to the beach all the time. We're going to be mountain people, or we're going to have a staycation, or we're going to find something else where we can make a difference in this world, shine his light on people, and we're going to enjoy each other's company doing something else. Not what we used to do. It's going to be different, but it doesn't have to be worse. So it's figuring it out and not saying, oh, well, we can't do this anymore, so life's bad. You're resourceful, figure out what you can do to make it a meaningful existence together. Things happen in life. We get curveballs and we have to adjust to them, right?
By the way, there's another thing in that you have a large MS community around. Maybe you should find those that are activists, okay, and speak with them, and find these advocates that you can talk with and just have an outlet for your emotions.
Oh, okay. No. Okay. I just want to say, Dr. LaGanke is my doctor. I come to him all the time and call him when I need him. But I've been in this chair for 10 years, and I ask him all the time, what can I do to walk? But it's a process. I have to do physical therapy and this and that, But I'm 63 now, and I always ask him, but I'm getting better. Physical therapy, I take it twice a week, And I got my son here. He's been with me through thick and thin. And I want to tell everybody that just give him a hand, because he been with me, y'all. Just don't know. And he need a good woman, but he helping me, and they're taking away from him, but he been right there for me, y'all.
You're not taking away from him, you're blessing him. He's doing for you, which is doing for someone else, which is a blessing. You're helping him to be sensitive, to understand, to commit himself to someone he loves. Those are good things. Those aren't taking away from him, okay?
Amen.
Best drug you can take for smoldering MS, and can you explain smoldering MS a little bit more?
How much more time do we have? So that's a giant question, and it's not one size fits all. This is not a guarantee for a limited time only for $9.99. If you take this drug, the smoldering MS will go bye-bye. It's a process by which we game out what we think might help. We apply it. We watch carefully the way that we've weighed out today, and then we reassess.
Thank you. Please explain the difference between the acute process versus chronic smoldering process.
The acute process is active inflammation. Some turned on T cells went to the brain or spinal cord and caused havoc, which elicited a chemical response and an immunological response that led to inflammation and damage. That's the acute process. And the smoldering process is that maybe the inflammation is quieted down some, but it's still kind of hanging on. So we see some people with active lesions 6-7 months later, it's still kind of there. The immune system wasn't able to stop that, or the steroid that was given or whatever didn't stop that, and they're kind of smoldering along from that kind of a smoldering lesion. With smoldering MS, if it's kind of Pira-ish, which that term is kind of adulterated, smoldering MS, it's not really greatly defined as to what you're talking about. But if it's kind of progressing a little bit along and it's not actively inflamed acutely, then maybe a different part of the immune system's involved. Maybe the monocyte, macrophage, or microglia part of the immune system is now involved, and that may require a different kind of treatment approach, which hopefully we'll have at the end of September, another product that's available to treat that.
Thank you. So similar to the gentleman in the back, a person's writing about heat and humidity and getting extreme spasticity from this, especially for walking just 10 minutes outside. Is there some kind of medication they can take to help prevent this?
So many people impacted by MS experience something very unpleasant when they get overheated, whether that be because they're having sex or they live in Coleman, Alabama in the summer, or they're exercising on a treadmill. When they get overheated, they can short circuit and they can start to have problems. They can start to get weakness, etc. There's a medicine called 4-aminopyridine, or Ampira. And 4-aminopyridine is a medicine that only works in about a third to half of people that try it. It's a pill twice a day. But when they respond to it, it buttresses against heat sensitivity. Now, I'm not smart enough to figure out who's going to respond and who doesn't. So as long as you don't have any reasons that it's not safe to take, then I try to give it to you for 2 months and we sort it out. And if it works, yay. And if it doesn't, I'm sorry. There's other things we can do in addition to medicines, like cooling vests or cooling kerchiefs, which can help cool the core body temperature, or choosing to exercise in a swimming pool where the water wicks away the heat, or choosing to go on a promenade after the sun is setting towards the end of your day or before the sun comes up. So there's a lot of things we can do to combat heat sensitivity and motor fatigue.
Yeah, that's great. Now, if it's spasticity, they're getting spastic in the heat, that's kind of counter. We expect that in Ohio in the winter, and we're kind of rag dolls and very weak in the summer here. But if someone's having spasticity, it could be a shorting out. It just happens to go in that pathway. But you have to think about electrolyte deficiencies. They may be seizing up or spasming because they don't have electrolytes in the hot temperature, and they have a calcium, magnesium, or something else difficulty, or they're not hydrating. The muscles are dehydrated, so we have to hydrate very well. And the other thing is, in the summer, having more spasticity in the South, well, we have something called air conditioning. And sometimes that air conditioning is quite cold and quite a contrast to being outside. So your warmed up muscles outside, now you come inside. Well, I can't have spasticity. It's 100 degrees outside and I'm not in Ohio. But lo and behold, you come into the cold for a period of time and you can spaz up. So it's not just all winter, summer, it's cold temperature too.
Thank you. Is it better for a person who often falls to be taking calcium?
So people impacted by MS over the age of 50, boys and girls, independent from steroid exposure, are at risk of thinning bones faster than the general population. That's very serious, because if you fall and you have thinning bones, you can have a fractured hip. And so In my patients who are over the age of 50, I like to make sure they get a bone density scan every couple years. I think that's a best practice to make sure that we know the status of the bones. I don't ever want you to fall. Every single clinic visit, I ask my patients, have you fallen? And if you have, we need to game out what happened. You got drunk? All right, well, please be careful. Your kid left a toy on the ground? Okay. Your leg gave out, you have bowel problems, you couldn't feel your leg. We have to game out why you fell, and we have to do things to prevent that from happening.
And ideally, kind of the team approach is Aaron shouldn't have to be doing the bone density. He shouldn't have to be thinking. He does because he cares about you, he loves you, and he's going to make sure that that's looked at. But ideally, the team, the primary care, the OBGYN, the other people in your team are going to be ordering that test because that's typically what they do. And who cares for that problem? He shouldn't have to. He's busy enough. His YouTube channel might suffer if he's having to do too many bone density events. So, so that's another way proactively. What can you do and what homework? Well, have I had my bone density over 50? I'm postmenopausal. Have I had this or that? And just kind of an unrelated, totally off script kind of thing with postmenopausal women. The American Neurological Association about 8 weeks ago came out with guidelines on menopause. I have not met a woman who's been educated on menopause by a doctor. You learn on the fly. You learn by word of mouth. But these guidelines are out there now. It took them 6 years to make them. And one thing that they found that's relevant to our population, 70% reduction in death rate by using intravaginal estrogen, which prevents urinary tract infections and urosepsis, and something that's very underutilized. No breast cancer, no ovarian cancer, no blood clots with intravaginal estrogen that they tested in tens of thousands of women. So I think getting those guidelines, looking those guidelines up, American Urological Association guidelines on menopause can be very educational, and it can allow you to maybe have a discussion with those who might prescribe that medication that hopefully is not Dr. Boster and myself. Hopefully it's a part of your team that does that, and that they order the bone density tested, that they make sure you have your pneumonia shot, or if you wanted shingles, or that they're doing what they do with the rest of their population.
Thank you. A gentleman writes that he doesn't feel that his fatigue is caused by his multiple sclerosis. He believes it's more because he's over 50 and wants to know what kind of hormone therapy replacement he might need.
So there's some data that suggests that gentlemen with multiple sclerosis that have low levels of testosterone have increase in fatigue, increase in depression, increase in cog fog. And some studies even suggest they can get worse faster. And so I check testosterone levels in all the gentlemen that I take care of. And if we find that they have low levels, then we start to engage in a discussion about testosterone replacement therapy.
Thank you. Next, is there any effort to develop a positive MS diagnostic method? Is there any way to diagnose MS quicker?
Hopefully not, because we're failing otherwise. But yeah, not that I know of. That not a faster way than what we do at this time.
5 things to diagnose MS: your story, your exam, your imaging, your spinal fluid. Prove it's nothing else.
Gotcha. Next, when might the Perseus study complete for the B-cell depleted for primary progressive?
So there are studies for primary progressive MS and B-cell depleters, which is ocrelizumab, and that was found to be effective in primary progressive MS, so has been approved for primary progressive MS, if that's the question.
I don't know. I'm not there. Okay, next one is writing, if B-cell depleting drug therapy doesn't work, and if my T cells are not working based on MFTHR gene, what do you recommend until B cells grow back?
So MS therapeutics is rather complex. And when we talk about B and T cells, that's not remotely the entire story. We're simplifying things. There's a lot of cells that are involved. Dr. LaGanke spoke about microglia just a second ago. It's much more complex than if the B cells don't work, then talk to the T cells. In modern therapeutics, I say that in parentheses, we're trying something, and if it works, then yay, and if not, we try something different. And the individual human being with the individual situation, we got to game out what works best for them. It's not an exact science.
Thank you. Next one, are Dawson's fingers always indicative of MS?
No, they're very helpful radiographically when a person has them and you're suspecting MS. It may be very helpful to see those in order to assist you in your diagnosis. But Dawson fingers can occur with other things as well, especially once one gets older. So over 50, the blur between MS and hardening of the arteries or microangiopathy becomes very close together.
Okay. The next one, Epstein-Barr. He or she writes, I've never had Epstein-Barr, yet here I am with secondary progressive MS.
So there was a study done in the United States around 2019, which looked at 10 million people in the military, and it determined that 95% had been exposed to EBV, Epstein-Barr, kissing flu, glandular fever. 95%. Now, that doesn't mean 95% of people missed high school because they were sick at home. It just means they had been exposed to the EBV virus and it tested positive. In that 10 million people they looked at, 800 had MS. Every single person with MS in that study except one had been exposed to EBV. So it was like 99.9%. That's highly statistically significant. And we now believe that developing EBV, coming in contact with the virus, might be part of the process to develop MS. That does not mean that you had to miss high school for 3 months and have big swollen glands. It means that you may have been exposed and not had any symptoms.
Thank you. Next. How do we improve fatigue if Briumvi made our fatigue awful, awful, awful?
How do we improve fatigue if what?
If a person's taking Briumvi and they've actually gotten more fatigue from using Briumvi than prior.
Well, I mean, if any medication makes a person function worse and you're pretty clear that it's the medication, well, we won't be staying on that medication very long because we may stop MS, but if your quality of life's horrible, we're not going to be an advocate for you to continue on that therapy. You want to make sure there aren't other things going on that may be causing the fatigue and maybe try to treat the fatigue if one hasn't to see if we can improve that and maintain a therapy if it's effective. But pretty much if a medication has a side effect that's significantly affecting a person's quality of life, we're not going to hang there too long.
I'm in the middle of reading somebody's very long question, but I'll get back to that in a minute. Going back to the Tysabri, person writes, I've been on Tysabri and had 7 octave tests. What treatment would you have gone to next? Evidently, the person's not doing so well.
I think what the person said was, I'm taking an MS medicine, in this case Tysabri, and I got that octave test, and I have a very high number. What does that mean? That means that there's a suggestion that things might not be as stable as we think. Now, am I going to make a unilateral decision based on that one octave test? Probably not. I might want to repeat it to see how it changes over time. I may want to get an MRI if I haven't gotten one. I may want to take a careful history and do a little bit better of a neuro exam and try to dig in to figure out what's a cooking.
Okay, how do you slow PPMS progression?
Well, at the present, there's one medication that's approved for it. We may have a second one shortly, but as far as stopping progression, that's all that we really have. I mean, there were other agents. So chemotherapy agents, depending on how the person's going, might be something that one would look at. So Novantron Cytoxan were used for progressive MS back 2000. Unfortunately, with Novantron, 1 in 150 people develop leukemia, and it has some dose-limiting cardiac toxicity effects. So you can only take it for a certain period of time. But I think if we have nothing else and one's going downhill in front of our eyes, stem cell therapy, we're going to look at some kind of aggressive treatment that may not have great statistics behind it, but is plausible to be used in that particular instance. I don't know if you have anything else.
Okay, next is, where'd it go? Is caffeine bad for MS?
Nah.
Okay. Is there any medication that's appropriate for somebody over 60 who was diagnosed with MS 49 years ago, but had never been on a DMT?
Yeah. It's important that we're not ageist. All right. 60 is not magic, particularly as I get closer to that age. And so Yeah, so the goal is to treat you and help you live your best life. Just because you had a birthday, I mean, that's a lot of candles, but giddy up. We're going to treat you with a DMT.
Okay, let me read this to you. I was on Copaxone for 23 years and diagnosed in 2001. I became injection fatigued as my MRI scans had been stable for over 10 years and no relapses in over 15. My neurologist recommended, now that I'm in my 60s, it would be safer not to change to any new DMT, and studies are showing it makes sense to stop DMT than to risk side effects. She's concerned that her doctor is not making the right decision. Can you reply?
Well, there's not a right or wrong decision. You know, that'll be decided at the end of the day. So, but my take on it and how I would approach that is that, well, you've been on a therapy and you've been very stable for quite some time. I would want you to continue on some form of therapy. But again, sort of like the fatigue question before, if you're running out of real estate, the shots are just, impossible. You have lumps, you can't get the medicine in because you inject into a lump and it spills out, and it's just not working for you. You have shot fatigue, which kudos to you for 23 years taking that shot. I mean, that's remarkably good. I would look to choose a different agent, and that agent is going to depend on a bunch of different things. I won't say which agent I would, but we'd kind of work with that person, their lifestyle, and decide what might be an appropriate, acceptable approach.
Thank you. Next, do some patients not do well on B-cell depleting drugs? And if that's the case, where would you go to next if you failed Tysabri?
So everybody's an individual, and not everybody's going to respond to every therapy. And sure, there's plenty of people that try a therapy and it doesn't work out. And again, it's too complex of a situation to be able to give you a one-size-fits-all. If we have a situation in clinic where something ain't working out, I got a whiteboard and I write up every drug you've been on and why you had to stop. And then I write up every drug that you haven't gone on yet. And then we talk through them and we find one that's a good fit.
Next question. How many like today's program? How many would like to see that combination again? How many would go to Ohio to see the reverse being done up there? So thank you both. We are out of questions.
And thank you, Stu. You know, you have 16, 18 more programs this year. He's on the road all the time, bringing these to communities to share information and help educate people with MS. So really appreciate what you do.
Thank you again, everybody.